This is our annual healthcare conference that the department's been sponsoring for some 20 years now. And of course, it's very timely with the continued rollout, implementation of the Affordable Care Act, which it's hard to believe is now in its 5th year since passage, and we still see Supreme Court arguments and potential major changes for 3/4 of the states if the wording of the act that says only states with a state-sponsored exchange will be eligible for subsidies means what it appears to say. Who knows? And only the Supreme Court can tell us in a final decision what the implications of that will be for what is now 90% of 184,000 enrollees in our state receiving subsidy for their health insurance. They would lose that subsidy if the Supreme Court decision went the other way, and if some quick fix was not applied to address that glitch in the act. That's just one of the many issues that we will be discussing here today. We will have updates from national as well as local and state officials and executives from the agent forces in the insurance industry and the companies doing business in our state, as well as input from consumer representatives throughout the day. So we're excited. It's a challenging issue, challenging times in the health insurance arena, but that's why we're looking forward to a day of robust discussion and perhaps some innovative ideas that we can take to the legislature this spring and make things better for consumers of health insurance throughout our state.
The changes that we're facing are constant, and they affect everybody. Everything from concerns about what the United States Supreme Court might do with respect to validating the subsidies, to the many new enrollees that have enrolled in the federal exchange that now, should have been probably a state exchange because the statute provided that it be a state exchange, although it's probably being interpreted by the IRS to include all people that signed up. So that's a very big issue, and if those folks lose the subsidy, they may also lose their insurance, which could create additional and expensive premiums for all of us by way of having to pay for more people that are uninsured in Louisiana. We're also going to learn a lot about what's happening with the serious impact to the deficits in the state legislative budget. In Louisiana, we're facing even greater challenges, which I'm sure we'll hear more about from our speakers today, because as you know, Louisiana is so terribly dependent on a commodity exchange called oil and gas. And when the price of oil, crude oil, goes down by even $1 a barrel, our deficit goes up, and our Constitution requires a balanced budget. So because of that, there are really only two places to try to fill a gap of what I think at the last estimates would be over $1.6 billion in deficit that we somehow have to make up in only two places, higher ed and healthcare. And we know that everybody is working diligently to try to make sure that the pains from those cuts are not felt by everybody, but will be felt by everybody. And so we wish well to our elected officials. They've got a tough legislative session ahead.
Relative to the Affordable Care Act, I'd like to take a few minutes to tell you how we are dealing with it and how we are experiencing the challenges. Last year in Louisiana, we saw more competition in the major medical market with the addition of a new insurer to our market and the expansion of an existing insurer from a regional carrier to one doing business throughout our state. Open enrollment for this year just concluded last month, and we have now 184,000 of our fellow residents registered online through healthcare.gov, the federally sponsored exchange that serves consumers in our state, up from just over 100,000 1 year ago. And 90% of those folks are receiving subsidies, as the only way you can receive the federal subsidy provided by the Affordable Care Act is by accessing your coverage through the exchange. As Donna mentioned, just last week, the Supreme Court heard arguments in King versus Burwell, which is a lawsuit focused on the fact that the Affordable Care Act says in its language that only states with a state-sponsored exchange will their citizens be eligible for that subsidy. If that exact wording is the ruling of the Supreme Court, then 2/3 of the states will face the challenge that we have, with 90% of those 184,000 enrollees losing that subsidy that they are enjoying today. Today, 5 years after the passage of the Affordable Care Act, we're still dealing with the possibility of significant changes as King versus Burrell represents. And we'll hear today from representatives from CMS and the NAIC on the Affordable Care Act and its implications. Donna mentioned my year as president of the NAIC 2 years ago. It was during that year that the issue of unqualified plans that did not meet the requirements of the Affordable Care Act, I generally refer to them as high deductible plans, that millions of folks across America had in place and were, quote, satisfied with at that time. And when they started receiving their notices of non-continuation or cancellation, if you will, of those policies, the political hue and cry went out, and the White House responded by offering the state regulators the option to extend that coverage, first for 1 year, and then this year, 2015, and then for another year, 2016. And most of my colleagues and myself took up the offer from the White House and did extend eligibility for that coverage for not just 2015, but recently I issued another bulletin extending that coverage through 2016 as well. Let me finish by just giving you a couple of recent things that we've done at our Department of Insurance here in Baton Rouge. Health and rate form filings are now available on our LDI website. It's a new online system called SURF Filing Access, and it allows anyone to access form and rate filings for this calendar year of 2015. That system was launched at the end of 2014 and provides a simpler way to access rate and form filings in Louisiana. We are doing that along with 23 other states through the sponsorship of the National Association of Insurance Commissioners. Also at the beginning of this year, the department launched a new online system for IRO external reviews. Through this online system, insurers who need an external review of a benefit decision supply the information requested, and an independent review organization, or IRO, will be randomly assigned to the case through our website. Consumers who are notified that their case does not justify an external review can also use the system to appeal that adverse decision.
How do we make healthcare sustainable in Louisiana? We know what we have in terms of our budget limitations, our resources. As Donna said, we're constantly faced, both healthcare and higher ed, with the only reductions that are the only places where reductions can be made. We have to figure out a way to make our healthcare more sustainable. And so we know we've been working over the last, especially over the last 3 to 5 years, to really change the way that we're delivering healthcare services, and if not necessarily providing a sustainable path, at least a more predictable path in terms of what our healthcare costs and what it means in terms of our budget and the state, and to be able to provide healthcare to both the uninsured and to the poor through our Medicaid programs. So one of the things, again, as you know, we've done over the last several years is transformed our charity hospital system with private partners throughout the state. We started in April of 2012. We started with the first partnership here in Baton Rouge. All of the partners at April of 2012, it was April of 2013 that we actually began that partnership. The partnerships have been significant in terms of the things that have changed in terms of healthcare delivery for the uninsured. We no longer have a two-tiered system. Previously, if you wanted things like an MRI and you didn't have insurance, and even an MRI not for an injury that your knee was hurting, an MRI for a tumor to get more official diagnosis about a cancer, you sometimes had to wait 6 to 9 months to get that MRI if you were uninsured. Totally unacceptable certainly for anybody in Louisiana to have to wait that long to receive an MRI. And that was the case if you went from all of our charity hospital systems and looked at the waiting list for MRIs, for mammograms, for many, many diagnostic services. That wait was that long. And to get any type of outpatient care in a specialty clinic, orthopedics, follow-up for surgeries, again, a significant wait times for all of those services. Prior to the transformation into the partnerships, there had been some major reductions to LSU causing closures of clinics, OBGYN clinics, surgical clinics, orthopedic clinics. Again, making people not only have to wait for a really long time for services, but often traveling from Lafayette to Shreveport to be able to get the necessary services. So when we changed this and moved to private partners, one of the best things that we saw were the reduction in those wait times and reopening of clinics that were previously needed in areas so people didn't have to travel so far. A major shift in terms of the care for the uninsured, and we continue to see successes every day. We have data from every partnership that shows the reduction in those wait times, the increase in clinics, the increase in the number of people they're seeing in their outpatient clinics, being able to handle things prior to admissions to hospitals. Again, all very different from what our care was before in the old state-run charity hospital system. The CEA is one of the big things that was I wouldn't say holding up our progress on this, but certainly made us nervous in terms of our partnerships, was it took us a really long time to get approval from the Centers for Medicaid and Medicare Services for the funding mechanisms that we arranged to be able to use our DSH funding, our disproportionate share funding, and our uncompensated care to fund those programs. It took us well over a year and a half to get those approvals through the federal Medicaid office, but we did receive those back in December, so we now have stable financing mechanisms to be able to assure that those partnerships, again, are going to be able to continue the many successes that we've had over the past year and a half. Again, these are just some of the things we continuously see. Clinics serving more patients, new urgent care centers all throughout the state. The private partners have opened up urgent care centers to allow 24/7 care outside of an emergency room or a hospital, reopened specialty clinics, increased ER capacity, reopened psych beds, detox beds that were previously closed, and again, some of the other clinics like orthopedics, cardiology, urology, oncology, gynecology, and many, many more that have been reopened that were previously closed due to insufficient funding in the LSU system. Next big area in terms of again, our changes, the primary thing that we've done with the partnerships, of course, is really change our what we provide to the uninsured. For people who are on Medicaid, previously people who are on Medicaid had no real, it wasn't at all like any of us receive in terms of services. They basically went to a doctor, got services, got paid for those services. There was no management of those services, no type of disease management programs that were put in place for individuals to really monitor and prevent emergency room visits as well as hospitalizations, no efforts to reduce hospitalization, no efforts to increase our preventative care. And no real efforts to find providers in gap areas throughout the state. Medicaid really was just a payer of services. And again, you can see some of the statistics. I won't go over all of them, but people didn't receive their preventative cervical cancer screenings. They didn't receive breast cancer screening. Adolescents, children, only 25% had a WellCare visit for a child or adolescent previously in our fee-for-service Medicaid. We started our Bayou Health plans in February of 2012, weren't fully implemented till June of 2012. And so we're really just barely, we're not even fully 3 years into some of those programs, some of them that didn't start until June of 2012. But significant changes in terms of what we've seen in terms of individuals and their preventative care. Better care for diabetes, 7% increase in comprehensive diabetes care. And again, this is just really a difference in 2 years where our data was most complete. We have 2 full years of data. Adult access to preventative care, a 5% increase in that adult access to preventative care. Again, previously not available in our traditional fee-for-service Medicaid. One of the things we're probably most proud of is our focus on children and adolescents. These are significant number increases over the 2-year period that we looked at. 25% up to almost 46.5%, almost double individuals receiving adolescents' well care visits. Similar on the well child visits for young children, 35% up to 67.5%. How were we able to make these changes? You know, why didn't we do it before? Medicaid, again, was set up as a payer system. We didn't have the resources to be able to be a managed care system, to manage services, and really direct care towards preventative care. Through use of what we call money measures, which is measures that we either pay more for or take back money for if they don't meet those, healthcare plans have to deliver on the things that we determine as a state and as a department are priority in terms of care. So of course we focused on preventative care, trying to make sure that we were providing those services to prevent those hospitalizations, prevent emergency room visitations. We're just really at the beginning of managing this care, so our primary things that we focused on were process things, making sure that they were getting that preventative care. It will be several years before we see true outcomes. Did this adolescent well child visit or those well child visits for children get people, get kids to be on asthma preventative programs to reduce those hospitalizations? We're tracking that. We're seeing small reductions in that. Overall health outcomes, though, will take many years to come. But we certainly feel that we're on the right track in terms of rewarding those things and having health plans perform in the areas where we as a state know we need to go and where as a department we know we want our priorities. One of the best things about this, of course, is that it's also saving us money. Again, that was part of one of the major reasons when we were first moved to a managed care system. But for many of us, the real reason was the outcomes, not the cost. However, wonderful in terms of where we are, both in terms of predictability, but also in terms of cost savings. Difference of $12.81 between our prepaid plans and our shared savings plans. Our shared savings use fee-for-service Medicaid, but then also we're paid a management fee on top of that, and we're able to incentivize providers to make changes with the service, with the management that they provided. For the legacy Medicaid and the prepaid plans, additional 16.74 cents per member per month. Remember, we have a little under 1 million people in our Bayou Health plans. So when you translate that $29.55 for every member per month, it's a lot of money that we were able to save. We built in $135 million in our first year. We continue to save money, and again, it really helps us in terms of growth of services. We know we can predict based on the number of people that we have exactly how much it's going to cost us. We no longer have to wait for those bills to come in and figure out how much this particular person cost, and did we have some outliers that really blew our budget. We now know we are going to pay so much per member per month for all of the individuals in our Bayou Health plans. So again, significant savings, especially of course in our prepaid plans, which we have moved as of February 1st to all prepaid plans. So again, more predictability in our budget, continue to be able to provide us savings, so again, that we can focus our dollars on the things that we want to reward and the performance that we want to see in our health care plans.
Our biggest change has been in the preventative services. One of the things we weren't able to do in traditional fee-for-service Medicaid is really manage the type of care that people get or incentivize the type of care that providers provided. So now that we can do that, we're seeing things like from 25 to 50% in our adolescent well care visits, from 35 to 68% in our child well care visits. Diabetes screening going up about another 7%. So significant changes in preventative type care because we're now able to incentivize those, work with our health plans to make sure that they're incentivizing providers to be able to get those outcomes that we want.
Now then, in Louisiana, can we say thank you so much, and how excited we are. Louisiana led the nation in the increase in the number of folks who received insurance, who bought insurance through the health insurance marketplace over 2014. For 2015, we had a total of 134,532 consumers who either re-enrolled or purchased insurance for the first time through the health insurance marketplace. If we break that down, the New Orleans and Metairie area is just over 62,000 people. In Baton Rouge, 37,000, just over 37,000 people who have enrolled. And then the balance, of course, is spread out across the state. Louisiana is like several of our other states in our Dallas region. We have a lot of rural area where we've got hard to reach populations, and we know that through the grassroots efforts that those folks were given an opportunity as well. And so it gives us an opportunity, once we get our demographic data, to see where are we most likely to find people who may not have even really heard anything about the health insurance marketplace. There are people who just don't pay attention to that kind of stuff, and so we want to make sure that we get the word out across the state. Louisiana led the nation in the increase in the number of people who are enrolled in the health insurance marketplace, which means, of course, it translates into more people receiving services, taking better care of themselves, and having the insurance that gives them the peace of mind that we want them to have.
Today I'm going to talk about ACA implementation, what has gone so far this year, 2015, and we're going to look at 2016 snapshot, and then I will talk about key issues related to state insurance regulators, such as network adequacy, state-federal coordination on various issues, and basically that's going to be my discussion today.
I was asked to talk about the state of health in the state of Louisiana. And as we're all aware, we're buffeted every year by the national health statistics and the rankings. The highest we ever reached was number 47. You can see that blip in 2009. Diabetes is taking a big toll on health care in the country. This map depicts the diabetes prevalence in all of the counties and parishes in the United States. And you can clearly see that we're in that diabetes belt, we're in the obesity belt, the hypertension belt, you name it. But that darker part of the country here, in terms of color, represents the diabetes belt. And we really know, nationally, the prevalence of diabetes has increased to about 9%, and Louisiana is substantially higher than that right now. We're sitting probably around 12% of diagnosed diabetes. We have a large population of undiagnosed as well. But that's where we are with diabetes, and of course this map looks almost identical. I did switch slides. This is the map of obesity in the United States. And we do know that obesity and diabetes track very well. So one of the primary targets of diabetes prevention is the reduction of obesity. That's the one thing we can do for diabetes. For heart disease, for example, we have other risk factors like smoking and high cholesterol and diet and nutrition, but really it's obesity for diabetes. And of course, the physical activity and nutrition feed into that, but if we can reduce our obesity rate, diabetes rates will fall. And I mentioned diet. Right now, there's a big focus on the diets of Americans and how this is leading to obesity and diabetes. However, Something that has also changed substantially over time is physical activity. And although the colors are different on this map, we see clearly that the south and central part of the United States is more physically inactive than other parts of the country. And actual physical inactivity is right now one of the leading risk factors for both heart disease, diabetes, and cancer. Unfortunately, we're going in the wrong direction. What we see is mortality rates are going down, but they're not going down as fast as the rest of the country. So it still puts us at quite a health disparity here in the state of Louisiana.
What is the condition with Louisiana's children right now?
Well, they certainly, they're experiencing high levels of obesity and physical inactivity, and this doesn't portend very well for their future health.
What is the answer?
Well, that's a good question. The entire country is struggling with this issue, and we all need to come together as a community, really, to fight childhood obesity, put in place the proper programs that will turn this around.
Do you think there's less or more money flowing into the healthcare system today than there was 5 years ago? A lot more, right? And so we're looking at this environment where people can buy a $700 insurance policy for $20 a month, right? And they can get their cost sharing covered so that their $1,900 deductible becomes zero. And we're trying to ask ourselves, where are there incentives there for people to help control costs and to do what needs to be done, especially as premiums escalate, because guess what? The uninsured were a little bit sicker than we thought they were, which is okay. They needed help and we gave it to them. That's the important thing. When we're subsidizing, actually in our block, 92% of the participants on healthcare.gov in our block are getting a subsidy, and the subsidy is averaging 70%. And then we've got these little bitty taxes and fees and things that we know have to come out of our business plans over the next few years and go into federal coffers to help pay for all this stuff. So we had to have a serious soul-searching discussion with ourselves as a carrier and say, do our normal methods of helping to control healthcare costs work anymore? When you go out to offer a renewal to a customer, and that renewal is too high, and he's not happy, which could be 5% or 25%, depending on the customer, right? What do you offer him? Well, you know, what we've really offered him in the past are things like higher deductibles, narrower networks, more restrictive drug plans, right? Maybe we tightened up his formulary a little bit too much. Maybe we raised copays. And then the docs that work for us held our feet to the fire and said, how does any of that make this guy healthier? How does any of this bring him to long-term health? And you know what? There's not a good answer for that, is there? There really isn't. In fact, it might actually have the opposite effect. So when we started doing that soul search, and what we realized is, our burning question is, how do I improve health and save money at the same time? Now, the wellness market has been very vigorous and very busy for the last few years. The results, I think, it's fair to say, have been mixed, all right? So what we're looking at now is we're saying, okay, our actuaries tell us that we have 4 people walking around out there, 4 clients walking around out there, who we consider low-hanging fruit. They are essentially a bad disease waiting to happen, right? They don't call Louisiana the beer and boudin state for nothing, okay? So we've got people out there walking around with chronic conditions. How close are they to moving from high cholesterol to a cardiac event? Well, think about just these 4 conditions that people already have. You know who you are. I'm one of them, so you know we'll form our own support group. But if I take an average pre-diabetic and I let this guy slide until he's insulin dependent, what's that going to cost me? Around $7 grand a year in new claims, average, all right? Just because I let him slide. What happens when the hypertensive have a stroke, even a tiny stroke, one that he might not even notice? When you average that out across the field, $15,000 in new claims in 90 days. What about when that guy with the high cholesterol has his first cardiac event? How about $21,500 in the first 5 days? And then there's chronic kidney disease, which in Louisiana, unfortunately, we enjoy a much higher percentage than we should. Now, folks who are on medication to control that, typically their costs will run $15,000 or $20,000 a year already. But if we let them deteriorate to stage 4 or 5 and go to hemodialysis, now we're talking $100,000 to $250,000 a year. Every employer that we support, every group, risk pool that we have, has these cases that haven't become acute yet, just walking around very close to becoming acute. So we asked ourselves, where's meaningful intervention start? Where is it going to work? Where is it going to make a difference? And we decided that the place it would matter is in the primary care doc's office. So we created a program called Quality Blue PC. It is a team-based, high-touch partnership between the patient, between his doctor, between us, and between his employer. All four of us committed to making sure that doc has the resources necessary to help this guy freeze right where he is in his progress toward acute disease, and maybe turn around and go back the other way a little bit, okay? So how do we do that? Well, keep in mind that if you want to motivate somebody, get their attention. We get their attention with money, all right? We pay the PCPs to manage these folks a fixed amount every month. As their conditions improve, the amount they get paid goes up. So they're actually reimbursed, not on a fee-for-service basis, but on an improvement basis to monitor this population. It's a big deal. As the patient gets better, the money goes up. And we invested up front. It's all keying on electronic medical records. We hired nurses who every Monday contact the practice manager and say, look, you're going to see 7 Blue Cross patients who are in this program this week. Here's a list of them, and here's all the medical records they got that came before you saw them, so that primary care doc knows what drugs they're on, what specialists they've seen, what tests they've had run, even if it happens somewhere else, as long as they had electronic medical records. And we give them the software to collect it, and our people call and talk to the docs and review those cases every Monday, even if it's later in the week. By the time that primary care doc walks into the door with that acute case, he knows more about them than anybody else in the healthcare system. And that knowledge comes because we want them to continue to be at the top of their practice. If they participate, we even fund their CPE. So when they need to go out and get training and get better at their job, they can rely on us to help them sharpen their axe, to give primary care docs resources they really haven't had before. Now, we've been at this a year now. This started January 1 of 14, believe it or not. And one of the first people to sign up, of course, was OGB. And they have done miraculous things. We can see in our total population already, after the first year, a 12% improvement in the diabetics we've measured over the course of the year, about a 28% increase in the health of the hypertensives, 32% in the cardiovascular disease, and most importantly, and perhaps the biggest savings of all, the people with chronic kidney disease, we've seen their numbers improve 69% as a group in a 12-month period. And now we have 31 clinics who are participating in this, 440 primary care docs scattered around the state who are already engaged. And we know for a fact that they're managing almost 150,000 Blue Cross members. 52,000 have been identified with chronic conditions. And the only thing stopping us from spreading this further into the marketplace is getting more and more docs up and running on electronic medical records and tying them into the program. This is the future. We put $4 million in extra doctor payments last year. Based on the numbers we're seeing of this health improving, it won't be long before ROI will be real, and we'll be able to talk about it, and we'll be able to have this conversation going forward. And on top of that, to get the people who are supposed to go to the doctor incented, for 2015, we're going to waive the first $15 of their copay if they show up at their doctor who's participating in the program. This is what I'm talking about when I talk about the future. We can whine and cry about the past. In fact, I'm quite good at it, I've noticed. But we believe that this is going to be the payment system going forward, and this is what I wanted to share with you guys today.
We are statewide now. We have an advantage. We've built our plan on great customer service, and that was one thing that our members told us time and time again in our focus group meetings, and as we continue to survey over the last 20 years, is don't lose your customer service and don't lose your touch with your member, and that also is our broker community as well. But our Affinity Health Group, it's basically a network within the network. We go out identifying the low-cost providers that are low cost, but actually helping us improve the quality of the health care and increasing our star rating. And those providers there, the members get extra benefits, maybe no copayment or lower copayments, and it's really worked out well for us. Our multi-loss ratio, our loss ratios through Affinity Health Group is significantly lower than our regular Vantage network. And so we're able to pass those savings along through lower copayments as well. So Affinity Health Group has definitely been a plus for us. The way Medicare works, if a particular person doesn't go have their wellness or their mammogram or their men get their colonoscopy, whatever, they don't take their Medicare away. They punish the health plan that they're in by lowering their star rating. So this group here, along with all of our providers, we're working hard as our friends at Humana and United probably know in the Medicare business, we're trying to get our star ratings up and working with the physicians to help improve the quality of the care and making sure that our members are getting all their wellness that they need to improve our star rating. You just can't identify someone as having diabetes. You have to show now where you can follow that patient and improve his hemoglobin A1C score. So it's not just paying claims anymore for the insurer. We're actually embedded deep with the physicians and trying to improve the quality of the care that we have.
The Affordable Care Act, I think, has been burdened with that lack of awareness and attention, evidenced by the fact that a year ago, the same subsidized insurance that was available through the exchange attracted 102,000 people in our state. 1 year later, it's 184,000. Nothing else changed, but I think the difference is awareness, finally paying attention and saying, hey, that's out there, we can go get it. And that's at the core of the theory of the Affordable Care Act, and that is to prevent adverse selection. You got to have everybody in the mix, in the pool. Another question, and we'll start with Dr. Trunk this time if we could. If there was one thing you could implement for effective cost containment, what would that be?
I would have patients more accountable for their outcomes, because right now we're trying to make the physicians accountable, and they're paying premiums and the employers are accountable if they're paying for the premium, and the government's paying subsidy on the premium. But again, at the core of good health, which is what you need to control costs, not just good health care, you need people to be more personally responsible for what they do. They need to be aware of what they need to do for the conditions they have, and even before they develop conditions, they need to be aware of what does it take to live a healthier lifestyle. What should I be doing? Should I be walking? What should I be doing? What should I weigh? I mean, how many people in this room can tell you what their blood pressure is, what their cholesterol is, what their weight is, and what it should be? And then, better yet, how many people can say what they're doing if their numbers aren't right, what they're doing to get to the right numbers? I mean, we can build a system and have payment models and everything, but again, at the core of it is a person's own health and what they're doing to improve it, rather than worrying about where are they going to go, what's their coverage or whatever. We have to have more people accountable, whether it's through wellness, through its benefit design, through employers working. Everybody has to be in on it. It can't just be those that are paying the premium or those that are delivering the care. Otherwise it won't work.
Mr. Justice?
Dr. Jones, our president and CEO, we were talking about this question, and we came to the conclusion after, I thought about it for about a week, and he thought about it for about 10 seconds, and he looked at me and he said, Billy, there's nothing you can do. There's no one thing you can do to have cost-effective health care. When you go by the Vantage buildings downtown Monroe or by the Blue Cross or United, Humana, the co-op, you see 1,000 people in those buildings doing 1,000 different things. And it takes all those moving parts to come together to make it cost effective, where you can squeak out your 1.5% to 2% profit. For instance, just this weekend, one of the nurses and I were talking, and just for chronic conditions, these are some of the departments we have. We have complex case management, general case management, social services case management, behavioral health case management, disease management, which I thought that's what all this was, but it is something different, home health case management, and transitional care case management, along with a quality improvement team that's helping do a lot of the things that Mike alluded to, helping the primary care physicians get the information they need so that we can help get our star ratings up. So we're doing a lot of things behind the scenes to try to have a cost-effective plan. What the member has and what we as the producers, independent producers, the insurance companies, these people walk around with an insurance card. They don't realize, and even some of the people out there selling our products don't realize a tenth of the things that we're doing every day to try to make this thing go. And I think that's why we're trying to educate our brokers more and more on our star ratings and what we're trying to do with the physicians so that you can pass that on to your members, how important it is to go get those wellness exams and the things that we need them to do. So, but we are advantaged trying to get all these things daily, improving these systems to try to make things cost effective. So I don't have one thing that we're doing. We've got 1,000 things we're doing.
Thank you, sir.
One of the things that I think that, for whatever reason has always been kind of the bee in my my bonnet that I would love to see changed is the how we could eliminate or mitigate the site of service differential. In other words, you know, we've looked at numbers. A very large national carrier put some numbers out a few years ago, and it was not us, that talked about, for example, in Nevada, when they pulled their numbers, an average spine MRI performed at a freestanding physician clinic would range anywhere from the low 300s to $700. The same MRI performed at a hospital in Nevada was anywhere from $1,500 to $2,300. So in simple terms, I mean, I think what we can see is exact same procedure triples in price simply depending on what building you walked into. You know, there are other examples out there. I know that, you know, we've dug into some numbers I've looked at where we had a certain provider group in Colorado, I believe, that charged $2,000 for a cardiac stress test. They were acquired by a hospital, and the very next year they charged $8,000 for the exact same procedure that less than 200 days prior was 1/4 of the cost. So for me, the elimination of or mitigation of the differential between sites and the service cost would be one of the things I would want to look at.
Thank you. Mr. Cimino? I think that one of the things that would help mitigate costs in some respects would be incentives to individuals, to companies, to providers, to watch chronic conditions, treat chronic conditions, address chronic conditions. There are organizations wherein they will go into an employer group, look at all of the chronic conditions that are prevalent in that employer group, and then implement programs to address those. We found that those programs work best when there is a carrot rather than a stick to the employees to participate in those programs and achieve those goals. I think there was some discussion here about incentives for providers to provide better outcomes, to address certain conditions more thoroughly. I think that especially when you have people that have not had coverage in the past, that is one of the things that they can understand, are incentives to get better and to stabilize their conditions. But again, it goes back to education, and I think education is one of the greatest challenges all of us will have in this new market that we participate in.
Thank you. Mr. Berto?
Yeah, I can say I'm in agreement with most of what has been said to my left. The healthcare system has so many moving parts. Picking out one thing is always a challenge, but what's become clear to me over the last 2 or 3 years is the path to controlling healthcare costs has to flow through disconnecting the system from fee-for-service. If we can't figure out a way to undo the fee-for-service incentive program, I don't think we'll ever get a handle on healthcare costs. My message today is that as health insurance carriers, we are very concerned about the way costs are rising, and we want to make sure that we focus on quality of care above all things. So I'm here today to talk about the Quality Blue program that's designed specifically to help people get healthier and save money at the same time.
Tell us a little bit about how this originated.
The plan originated when we took a look at the impact of the Health Care Act on cost overall. A lot more people have health insurance, there's a lot more money flowing through the system, and the traditional ways that we use to try to help control costs didn't seem as effective anymore. So our docs at Blue Cross came up with a new way to do it that improves a patient's health and can save money in the long run.
What kind of results have you seen so far?
It's brand new. We started it on January 1 of 14, but already we've seen a very large population of patients. We've seen their health improve measurably in just 1 year.
One of the main questions, comments, and or concerns that we see from the consumers, from our members, is the cost of healthcare. I mean, it is sort of that perpetual issue that we need to talk about. And so we're going to share some of our experiences around what we've seen as market drivers, what we would perhaps suggest, what we think may curb some of the increase in cost, and just generally the experiences that we've seen on the carrier side since the implementation of the Affordable Care Act.
The enrollment period that has just passed for individuals will be, they're extending another enrollment period beginning in the middle of this month to the end of April. If you have not already enrolled, take this opportunity to do so. And one of the most important things is to make sure that once you're enrolled, you pay your first premium in a timely fashion. One of the biggest issues we've had are people that don't pay in time and don't ever get activated. They call it effectuated. I would advise people to really pay attention to what they're looking for. Involve a broker if you're not familiar with insurance coverage. And again, make sure that once you do choose a plan and you are enrolled, that you do make your first payment so that you will be activated and you will have coverage. Because once that period of time is over, you can't go back and do it.
What has the Affordable Care Act meant for your business?
Well, actually, it helped put us on the map in the southern part of the state. We now have a much broader network of providers for our members to choose from. We still have a little bit of work to do there, but it went very well for us, and we've seen some people who were unable to get insurance now able to get insurance, whether it's pre-existing condition or they couldn't afford it. So the taxes on the front end are a little tough for some of the businesses and so forth, and are always debatable. But we did see the marketplace did have a new carrier come in with low cost, so the exchange worked like it was supposed to. It gives a lot of options to people who are looking for health insurance.
I think one of the biggest challenges we have is the lifestyle that Americans are leading. We need better engagement from everyone in terms of their own personal health. We know that about 70% of chronic conditions are influenced by lifestyle. It has a big impact. We eat too much, we exercise too little, and chronic conditions are growing. Diabetes, the obesity epidemic, hypertension, heart disease are even more prevalent now. So we really need individuals to take charge of their own health and work on preventive health care and maintaining a better lifestyle and really working with their primary care physicians to improve their health, not just treat the conditions that they have.
People with mental health needs also have huge substance use needs and also have huge physical health care needs. It's important to note that someone with the diagnosis of schizophrenia is likely to die 20 to 25 years before an individual without schizophrenia. And so the reason I'm saying that is because people with major mental health needs have huge physical health care needs, cause all sorts of issues for themselves and for the people around them.
Tell us what kind of improvements in mental health care have occurred in Louisiana over the last several years.
Well, since 2012 in managed care, March of 2012 when managed care was introduced, the network of providers has grown substantially. We now have over 1,700 individual and facility providers in Louisiana. And then within each category of providers, the number of eligible providers has grown. For instance, we now have psychologists and master's level clinicians reimbursed for mental health care for Medicaid patients for the first time, and that began in 2012. We have a number of facilities that serve individuals, and we have a huge growing home and community-based service provider set that has changed enormously since March of 2012.
Why is mental health so important to the community?
Because mental health is not something that's going to, poor mental health is not something that's going to happen or occur in a vacuum. If you have someone who has mental health or substance use issues, everyone around that person will be impacted, and impacted in not a positive way. So it's important to all of us that we help take care of those individuals who have mental health needs.
Presently, we've made progress over the last 10 years, tremendous progress. We're nowhere near where we need to be. Many of us believe that integrating the mental health with primary care is the most effective way to deliver this service, and we're at risk this year, particularly with the with the lack of funding that's made available, with maintaining the progress that we have made in the last several years.
Blue Cross, we really strive to ensure that we have an adequate network to provide care to Louisiana residents in relations to mental health and substance abuse. We provide or we assess our network every 2 years on average to ensure that we do have adequate coverage, and we really are striving to integrate chronic disease care and mental health care to ensure that those members with chronic conditions receive adequate care for their mental health conditions.
My chief message is that as a healthcare provider and as a clinician, I think the fundamental challenge is providing healthcare in a fashion which, of course, is fiscally reasonable, but at the same time which meets the needs of individuals with all kinds of mental health disorders, including people who unfortunately suffer from chronic forms of psychopathology who require a higher level of care. And I believe that's going to be the biggest challenge as years progress in terms of providing adequate care designed to meet the very true suffering that individuals suffer from in a way that is least restrictive and reasonable.
We'll be having a panel of insurance producers talking about issues that insurance agents are facing today in the health insurance market. We'll be talking a little bit about value-added services and how those agents can provide more value to their customers, and we'll be talking about how the federal exchange is working for insurance producers in Louisiana.
One of the issues that we're facing in Louisiana, not only us but everyone, is one of the questions that I brought up with CMS, is the fact that weekly the navigators are given weekly newsletters, educational newsletters, and webinars, and they refuse over and over to give it to agents. So we're not really playing on a fair playing field. So until we get to that point, agents and brokers are running up a hill. But we're going to get to the point where we're going to get that information. Either they're going to give it to us or we're going to legislate it federally.
The new open enrollment period gives those people a chance who haven't signed up yet to get in on the open enrollment for this year, and so they won't have to wait until next November to enroll. It's basically an extension that it was brought about by some people complaining that they didn't understand about the deadlines. Now, the federally facilitated market decided that they would allow people to enroll an extra month's time starting March 15th.
What advice do you have to people that will be considering enrolling?
Well, my advice would be to find a good insurance agent who can guide them through the process, explain all their options to them, make sure they get the right program at the right price, and maybe even a subsidy if they qualify for one.
I've been able to demonstrate that by changing the way employers define their total reward solutions, they're able to offer more of a complete package of benefits for their employees and do so quite affordably.
I want people to realize that healthcare is the responsibility not just of every individual, but every company and every person, because it impacts us all. One person gets sick or one person has some kind of disease, especially contagion disease, it affects the entire population. So healthcare is something that we all need to own and take responsibility for and find solutions.
Your reaction to everything that you've seen and heard here today?
Well, I think that the crowd alone speaks to how interested people are in healthcare, whether they're members of the insurance industry or whether they represent the provider community or they're consumers that walked in off the street to find out what's going on. I think it's obvious that everybody is concerned, not just for their health and the health of their families, but the health of their businesses as well.
I'd like them, first and foremost, to know they can always reach out to us for issues and concerns they may have. The confusion continues with that very cumbersome rollout and the complexity of this new health insurance system. Our 800 number, 259-5300, is always available to insurance consumers, and we would welcome their reaching out to us with any of their concerns. We also would hope that as a result of all the expertise that's being brought to bear today at our conference, that we would come away with some suggestions, some ideas that would make things better for health insurance consumers throughout Louisiana.
Your reaction to everything that you've seen and heard here today?
Well, I think it's been very positive. I like the fact that we had almost 1,000 attendees, and we had a lively discussion and lots of give and take between experts from the national, state, and industry level. And with that input, I think we will be able to tweak the system in ways that can make it more beneficial to policyholders.
If people have questions like more information, what should they do?
Please contact us, 1-800-259-5300, or go to our website, ldi.la.gov, 800-259-5300.